The stent grafts, that was easy, I guess. This one is not going to be easy. So paclitaxel-coated balloons, we have seen that in the session yesterday. Very debatable. So we'll take a look at what we have, disclosures. And these are the available devices. Again, the first three of them, which is the Lutonix, Impact, and Aperto, seem to be the ones that have been heavily studied based on the number of patients, as you can see here in this table. So the first one, which is the first study, which was done by Dr. Katsanos in 2012, compared again 20 patients with paclitaxel-coated balloons versus standard balloons, and showed definitely that there is a positive signal there. There is improvement in the target lesion primary patency and dialysis circuit primary patency as well. This was carried over by Dr. Kitro to publish the one-year results, again showing positive results, as you can see in these graphs. When they did subgroup analysis, it seems like the AV grafts seem to respond better than the arteriovenous fistulas. There was also a cost savings of almost 2,000 euros per primary patency year. So Dr. Kitro again did another study on the arteriovenous fistulas, trying to see if, long-term, that would result in, a positive result of using the paclitaxel-coated balloons. And actually, that study, as you can see from the p-values, was positive. This is the randomized pivotal trial by Dr. Triatola. And it's a 2-year results, and you can see that at 9 months, there was a positive signal, positive results. However, at 2 years, that was not statistically significant. So there was a variable efficacy of the DC balloon angioplasty in AV fistulas based on that study. And then there's, again, different signals. Again, there is a study on the impact balloon, where you can see that, this is a study where patients were, again, randomized, and you can see that at 3 months, 6 months, and 12 months, there was actually no statistically significant difference between the two groups. Another study on Scandinavian population, 39 patients, again, randomized to drug-coated balloons versus, which was the impact versus, plain balloon or standard balloon angioplasty. At 1 year, there was actually statistically significant difference in favor of the plain balloon, which is, again, very surprising. And then there is another pivotal trial by Lockstein, on the impact balloon. There is almost 170 and 160 patients in each group. And the study showed a positive result in favor of the drug-coated balloon, the impact balloon, at 6 months and then 1 year, as well as the results were also published in a conference, I think up to 3 years, as you can see here, in England by Holden. So again, it shows that this is working, and it's actually long-term, up to 3 years. When you look at the results in general of all these studies, as you can see, there is variability in the balloons, but there's also variability in the results. And the variability mainly stems from variability in the patient population between the study, the various studies, variability in the lesions that were included in these studies, variability in terms of the devices, and variability in the execution of the study itself. So let's talk about the variability in the patient population. Geographic distribution, again, was very, very different between the study populations. Here's, for example, the two pivotal studies. You can see that the US population was different between the two studies. The Lockstein study was positive, while the Lutonix wasn't. But when you look at the overall patient population, you see that the difference in the target lesion primary patency was significant between the two groups or the two studies. Not really statistically, but it's like different, significantly different, I would say. But if you look at the US population only, that narrows down to 16 versus 11. Variability in the lesion, is based on the type of vascular access, AVFs versus grafts, prior thrombosis, stents, covered stents, the type of the fistula, the site of the fistula, the location of the target lesion, the characteristic of the cannulation zone, the presence of calcification, and the age of the AV fistula itself. All these are factors that can affect the results of the study. So here is another, table that shows all these studies, a significant difference between them in terms of the 6-month primary patency Even with the same type of balloon, you can see positive and negative studies all the way between all these studies. So a lot of variability between these studies. Variability in terms of the device itself, that's also very important. When you look at, the dose of the variability in terms of the device, when you look at the dose of the paclitaxel, it ranges from 2 to 3.5. So very variable between the different balloons, and also the excipient is also variable between the balloons. And we all know the study that was published by Dr. Katsanos that showed that the increase there's increased risk of death with the paclitaxel-coated balloons in the arterial system. So when you look at the safety of the Lutonic study, for example, there was really no safety signal up to 2 years. Same for the impact study. These are the two pivotal studies, no safety signal again up to 1 year. Again, it seems to be safe, so there should be some differences. Again, it might be related to the mortality of this population. It might be related to the fact that these are different circuits. So do we need really higher doses of paclitaxel? That's a question we need to answer. Another variability is in the execution of these studies in terms of the pre-dilatation, time to inflation, which is the transit time when you place the balloon until you actually inflate the balloon, the DC bead inflation time, and the primary endpoints. When you look at some of the studies did not even pre-dilate, like the first two studies that were published. There is this, for example, which the Lutonics is the only study that reported the transit time, which is again the time from insertion to inflation. The cardiologists actually have studied this, and they found out that transit time more than 25 minutes actually is associated with poor results. So you really have to put this balloon really quickly and inflate it. Inflation time again was very variable between these studies. So again, the more you inflate actually has been proven to be a better outcome. And as you can see, the cutoff here by the cardiologist again was 60 seconds. Again, does that apply to us? Do we have to inflate more than 2 minutes? Is the dialysis circuit different than the coronary arteries? So these are all questions that need answers. So in conclusion, there is definitely signals that show us that there is that the drug-coated balloons probably are could have a role in the treatment of these lesions, and because of all this variability, we need really more uniformity in the data standards and the study designs. However, we can keep beating our heads on the wall, but at the end of the day, we need to really try to work on improving these balloons, improving the technique, improving the or optimize the technique in order to provide more meaningful and durable clinical benefits, and also study which population really benefits from this. In other words, we need to transfer this into a personalized medicine. Which patients will benefit from this? Thank you.